We'll tell you a quick story. Didn't think we were going to get him today into a clerical mix-up, but he did clear his schedule and work it out for us to be here today, and we're grateful for that. Mark Haney with Wellstar Hospital. He's the Assistant Senior Vice President and Wellstar Paulding Hospital President. So everybody welcome Mark Haney.
Yeah, I'll elaborate on the mistake that was made, and that is Tuesday I'm on the board of Chattahoochee Technical College, and I was at a board meeting, and Tammy Collins, who's the secretary to the board, she says, well, I saw where you're speaking Thursday, and she said, hey, I'm not going to be there, and I said, where? And she told me, we called the hospital as soon as I got in the car, said, we got to check this out. And sure enough, back in February when I was supposed to talk, and then the snowstorm canceled the meeting, we rescheduled at that time, but for some reason it never made it to my phone or my calendar. And so that's good. We got the medical staff meeting going on right now at the hospital, but the good thing is we have a great team of leaders, we have a great staff, and I'm very comfortable just leaving and let them handle the medical staff meeting and let me come here and talk. And so I am very glad to be here. Really, I think it's better we're talking now than February, because before February, we got to talk, we would have been talking about what we expected, but now we can talk about what has happened. And most of you probably have seen the insides of the hospital. I was amazed somebody made a comment about our open house. We estimated our open house, when we had the public open house, that we had about 10,000 individuals on the campus. We had 6,000 that went through the hospital on tours. And we had people waiting 45 minutes to an hour to tour the hospital. Now, to me, it's just amazing to me to think somebody would wait 45 minutes to an hour to tour a hospital. But it was quite an event. The reason how we got to the 10,000, it was Lanier Parking, who was managing the parking, said they had parked 3,500 cars. They typically estimate 3 people on the average per car, therefore they estimated 10,000. And so whatever, it's a big event. We really appreciate how most of you have seen the inside of the hospital, but if not, I'm going to show you my baby pictures. And that's what I call this. This is our baby right now, it's new. The hospital, these are some great pictures at night at time. The facility looks very well at night as well as in the day, but it really highlights all the glass areas at night. And that was one of the things we wanted to focus on, is really bringing in a lot of natural light. When we had the first rendition of the hospital, they had the whole front of it in glass, but only about 50% of that glass was functional glass. And I said, I don't want to pay for glass that's going to be just decorative. And that's when we came up with this element right over the emergency room that, I guess there's a corner over here. But that area, over the emergency room, that's where we came up. We took the cost of the glass on the front and said, let's put it over here. And that's turned out to be very good, because when you're up on the floor, that became a waiting area. Outside, it's very decorative, but it's also a beacon to the ER. And so it works very well. Then another outside picture at night, very close up on the front entrance. The patient room, this is the med-surg patient room. For those that have not seen it, we did focus on having an area for the family to stay with the loved ones. And plus that unit that's in the window there allows the patient or the family to have their meals over there, because that centerpiece pops up into a table, and then the back of it actually pops out and becomes a bed for you. We built in the bathroom with what we call a sliding door. Some people call it the barn door. But one of the elements of that door is that we got it as close to the head of the bed as we could, so that when patients have to go to the restroom, the shorter distance, less likely they will fall. There's a handrail that's got a nightlight built into it, so they have something to hold on to. And then if they were to start to fall and grab the door, a hinge door would throw them out into the floor, and really it naturally throws them onto their heel. A sliding door actually would lower them down more to their knees and then to their heel. And so hopefully trying to decrease the number of falls, but if you're going to fall, trying to decrease the injury in the fall. And so we did a lot of elements in the room. It really went through a lot of thinking about how we did it. And I think in the future, you'll see more of these sliding doors in healthcare design. We did make the room very decorative, making it more home-like, trying to create a more peaceful environment, a large window. Let me say something about this window, because when you look there, you see all the trees out there. Well, 278 so right out there under those trees, but when you're laying in that bed, you're looking at the tops of the trees. And I tell you, Johnny Bond's pasture looks really well in the fall when he starts, he has all the rows of bales of hay out there, and you see that out in the field. It's pretty neat looking. But I was looking at a picture that looked almost like this for a hospital that's out in San Diego. But when you looked out the window, all you saw were big buildings out there. And it just really contrasts, I think, the view that patients have here at Paulding, being able to look at the trees. And I can tell you the ones on the opposite side of the hallway from this even has, I think, a better view, because there's a hillside out there that goes up. It's sort of like Lost Mountain. You don't see it when you're close to it, but when you're away from it, you do see that hillside. It's a beautiful hillside. So a lot of elements in the patient room. And this is an ICU room. Looks basically the same. The only difference in an ICU room is the built-in patient lift that's above the bed there. All the gases are on the outside of the head wall, where the other ones, they were behind the head wall, sort of hidden. And that's really because we have a requirement for more gas outlets, plus we have the requirement of the monitoring for the ICU that has to be on that head wall also. And then there's a glass door rather than a wood door. Other than that, all the features are exactly the same. The importance of that is, one, the ICU patients have the same amenities as the med-surg patients, but also as we need to expand, we just have to add basically change the head wall out, build in the patient lift, and change the door, and we have more ICU beds. So it decreases our costs of the expansion of ICU in the future, where we do expect with the aging population that we're going to have more and more needs for critical care as we grow. The nursing unit, if you've not seen it, is a very open design, and we did away with that central nursing station where all the nurses gather, and it's distributed out now. And I've got to tell this on Dr. Sachs. Dr. Sachs has said, you know, there's a part of it I don't like. He said, I used to go up and I could find my nurse right there at the nurse's station. I knew where they were. And he says, you know, now they're in the patient rooms all the time. And he says, I know that's good, but I just don't like it. But what I really like about, what really is working well with this, is we visited a lot of hospitals before we built this. Really, I had seen over 30 new hospital projects from 2009 to about a year before this one opened. Kept looking at what people were doing. And we went on a lot of units, and what we really realized in new hospital construction today is, because of the flooring, because of the ceiling tiles, they've done a great job of making it a quiet environment, because everything's so acoustical, it's absorbing the sound. But what happened when you had a traditional nursing unit, when people would go on the floor, they wouldn't be able to see staff because they're in these built-in walls. And the patients weren't sure staff was working. The doctors couldn't find them. And so we went with an open design for many reasons. One, we wanted people, because it's going to be quiet, we wanted them to know where the staff are. And typically when you're walking up and down the hall, you do see the staff. But we also didn't want to have any kind of barriers for the family and the patients to integrate with the staff. We wanted the family to feel comfortable going over to the coffee pot and getting some coffee if they want to. And also from a safety standpoint, if something's happening on one side of the hallway and they need additional help, rather than having all these walls where they have to go around them, they can cut right through and to assist. And so it's worked out great. We've had, most of you probably know, the hospital's been full since the day we opened, basically, or the week we opened. I mean, it was amazing how quickly it filled up. But this morning, 100% full on the 5th floor, 90% full on the 4th floor. You could go up there, it will be quiet, it will be calm, you won't see a lot of clutter in the hallways. The floors are working great. And that's one of the things I've told a lot of my friends in health design, because we've had people from San Diego, San Francisco, Chicago, St. Louis, several places across the country come down and look at what we're doing. And I've called them, and they came down before we opened, so a lot of them I've communicated to that the floors are working better than I've ever expected. It's been amazing to me to be 100% full, and you almost think you're the only one on the floor because it's quiet, if you didn't see other people. Let's see what my next one is. Just another look at the hallway, but this is looking down the hallway at the rooms. The ORs, the surgery, has doubled. The number of inpatient surgery cases that we do has doubled. A lot of that's because the ER pretty much has increased by over 50% of what we were doing before. And where we were doing ER visits, we were doing about 40,000. We're doing 60,000 if we stay as we are on average. But we have some nights, okay, on average, if we see 165 a day, that's 60,000 a year. We have had about 10% of our days that we see over 200 that day. So the potential is very easy that we will be to 80,000. Our pro forma had us at 60,000 in year 5. We thought we'd go 40,000, 47, and just grow up to 60. We're already 60, so we imagine, you know, we're really going to grow from 60 to 80,000 in the next 3 years probably. And but the OR's business, the inpatient surgery business has grown because of that ER visit, because of people coming there that need surgery. Our outpatient business has not quite grown as much yet, but we have several doctors that are joining the staff now. They sort of waited till we got in. A lot of people waited to see what was going to happen. And they want, I tell you, April was a great month. People started saying, I better get on out there. And we've added infectious disease doctors that we've never had before, a lot of nephrologists we've haven't had before, some eye surgeons that are joining the staff, just to name a few. This is the pre and post-op area. This works great. This area, in most hospitals, you have one for surgery, one for the cath lab, one for the GI lab, and you have all this additional staffing because they're all in separate areas. This area is supporting all 3 of those functions. It is working great. The GI lab is actually, you see room 5 right there. GI lab is right behind room 5, right down past room 6 and 7. There's a cut through that goes to the cath lab. And the cath lab, by the way, did open the 2nd week we were in there. This week we're actually doing about 10 catheterizations, which is a busy week. We only budgeted to do 15 in a month for the first several months. And so we are exceeding that very well. We actually expect, we're waiting on one piece of equipment, and once that piece of equipment arrives, we'll be doing pacemakers and other kind of devices like that for the heart here at Paulding also. And the ER is working extremely well. Probably our biggest challenge for many reasons, but it's working well from a design standpoint, except for if I had to do over again, we probably would have built a bigger waiting area. But because people have had to wait. And a lot of that was that we didn't expect that kind of volume. Therefore, we didn't staff to that level. So immediately we had to bring in a lot of temporary type people. Wellstar actually has a department called Wellstar Temps, and it's a group of nurses that aren't designated for a specific facility shift and all that. So when we have gaps, we call Wellstar Temps. Wellstar Temps then sends staff over to us. So they're trained in Wellstar's procedures, policies, and so forth, but they're still not what I would always call owners versus renters. They're still just there temporarily. And so we opened, the first week we opened 30 new nursing positions. As soon as we saw how busy we got, rather than waiting to see if it stayed around. We just knew it was going to stay. So we went ahead and opened 30 new nursing positions. So that was in April. It takes us about 4 weeks to get them all interviewed and so forth, and get them offers out, because we have to do background checks and so forth. Then they have to give notice where they're at. So we had a big group, about 20 start this week. And we've got another group starting in about 2 weeks that will be getting active in July. And then they have to get oriented. But we are moving rather fast on getting rid of what I would call the agency type nursing or the temporary nursing, and getting in that permanent nursing. And that's going to help us a lot, because you can't really work on your processes too well until you have that permanent staffing, because you're constantly retraining. The other thing is the number of doctors we had. We're adding a fourth, meaning right now what they have is one 24 hours a day, and then they have one that comes in. I think the one 24 hours a day represents 2 doctors, so that's 2. They have one that comes in the afternoon and stays to the evening, and that's 3. What they're going to do is now in July add a 4th, and they're going to have 2 that are there 24 hours a day. So that should help in the process also, because the biggest linchpin in the process is getting the doctor in, getting everything ordered, getting it out. So all that staff is changing. We're getting that done. We're focusing on our processes. And then many of you know that when we opened, we went on live on a new IT system called Epic. Wellstar has Epic now. All our hospitals are up on Epic. Our doctors are up on Epic. Piedmont has it. Children's Healthcare Atlanta has it. Grady has it. Kaiser uses it. And the neat thing about it is it's one medical record, whether you're in the doctor's office or the hospital. If your doctor has Epic and we have Epic, when they're looking at your medical record, they're looking at what happened in the hospital, what happened in the other doctor's office, what's happening in their office. It's all together. But also, if you were out in San Diego at Scripps, who has Epic, and you ended up in their ER and they wanted to know what was happening, you could give permission for them to access their Wellstar Epic record. And so they look at the medical record too. It's a tremendous system. Their system, Epic has basically, the Epic facilities represent about 54% of the population in the United States. So that's a tremendous benefit when you think about the ability to travel and have your medical record, or have your doctors just looking at what the other doctors did. You're not, hopefully not having to repeat it too much. I know a lot of people say, why do you keep asking for me? Why do you keep doing this? A lot of that is not because we don't have the information. A lot of it is to verify we got the right person with the right data we're looking at. And then in the hospital, we are required, like if you go for an x-ray, they should look at 2 patient identifiers. So they may say, let me see your armband, what's your birthday? And they're just, again, verifying that they have the right patient, trying to do the right procedure on the right patient. With that said, this was another great visual. We have had several patients that we have flown out, typically pediatrics. In our pediatric ER, we do have a pediatric trauma room. We call it trauma room. But any pediatric patient that's going to be flown out, we put into that room and get ready for the transport. But I'm very proud of the ambulance ramp in that one. There is no reason why we should not be able to handle high volumes of ambulances in times of disaster. It's a loop road also, and it's a loop drive there so that we can have one flow of traffic rather than ambulance traffic going head to head in a disaster situation. I'm an old EMT, so that's the kind of stuff I've looked at. I've been in several disaster drills where you went down almost a 1-lane road, and trying to mitigate each other was very difficult. So that was one of the things in our design we wanted to do. But you know, this ambulance entrance also is the roof to our loading dock. So it's multifunctional. It wasn't just put there for that reason. And then we talk about our air handlers that have the ultraviolet in it. This ultraviolet lighting is at an energy level that it mutates the DNA inside the microorganisms and the bacteria, the viruses and the bacteria, and it really kills it because it can't multiply. And that's the only way they stay alive is by multiplying. And so we have that in every air handler. There was a whole lot of TV coverage on that. And we actually, the first week, had a couple of ambulances come in that said, the people said, take me to the hospital that has the blue light. And then we have our geothermal, and it's working very well. Many of you probably don't, there's very few hospitals that has made the commitment to go 100% geothermal heating and cooling. We have no backup to this. We're doing it because the cost of the geothermal equal the cost of building a whole central plant. So if you try to go half and half, it really made no sense. But this is working extremely well. And for those that were there during the open houses in the winter, they got all the lobby floors and the elevator lobbies have pipes running through it, so we get the radiant heat as well as the air heat and cooling all through the years. And with that, I think I'm down to probably a lot of stuff I've already said. From an activity standpoint, I've already talked about our ER volume. It has resulted in longer waits, but we are focusing on our processes to speed that up. The inpatient units have been 80 to 90% occupied, which really creates longer waits in the ER. And that's where probably the most uncomfortable waits come, because those are people waiting in the ER for a room to open up. Because what happens in the hospital is you fill up at night, because the ER volumes are the highest from 3 in the afternoon to 1 in the morning. And that's when typically you're admitting a lot of patients. And so you come in the morning, the beds are full. And the doctors come in and they discharge folks, and we try to get them out by 2 or 3 o'clock. And then, because that's when the ER again gets busy. So 2 or 3 o'clock in the afternoon is when the beds start opening up that you can put patients in from the ER. Well, some of them might have came in at 6 o'clock the day before. So they've been in there for over 12 hours. And we try not to have that, but on some of those days, we do have that. Now, I've asked our staff, I said, if you have a patient that's waiting, and they've been here 4 to 6 hours, and they're waiting for a bed, I said, let's offer them, if we can find them a bed, Cobb or Kennesaw, do they want to be transferred there, or do they just want to stay here and be cared for in the ER? Most of them decide to stay in the ER, but we do want to have them check that choice. If they know, it's going to be a while, there may be a bed at Cobb or Kennesaw that they can go to. But most of them decide to stay with us. And so we have had some long waits, and I imagine you being out in the community have heard some of that, and so I thought that's one of the reasons I thought today was a great day to talk, because I can at least address that we are improving as far as the process of getting people in and out of the ER. Now, the only thing that's going to improve the bed situation is being able to build out the next floor. I'm working on a business case for that, but to be honest with you, the majority of the patients that we get come from other Wellstar hospitals. So from a business case standpoint, it's hard to have a good business case to invest a lot of money to steal from yourself. But what's been surprising is that we have a higher percentage. We only thought 10 to 15% of our patients would be new to Wellstar. We think it's closer to 30, maybe even up to 40 in some situations. And patients that have moved from another health system to Wellstar with the opening of the new hospital. So that helps the business case some. But we're still looking for community support. We appreciate we've had a lot of individuals that have named rooms, named gardens. We've got the Charles and Jeanette Hardy Atrium, and we do appreciate all those families' support, and all that has gone to go towards building out the next floor, but we still have a huge gap. It's about a $7 million project, the next floor. And our foundation has raised commitments of just a little over $1 million to get the next floor built. So we're continuing to work on that, but we do appreciate what we have received already. And then a couple other elements that I think is important is when you look up high, the percentage that came from Paulding, the percentage that came from Cobb, the percentage that came from Pope, percentage from Carroll County. the percentages are almost all the same. We've had a little bit of change in Powder Springs zip code. We've had a little change in Douglasville zip code because we got a lot of Douglasville zip code that dips into Paulding County. We've seen a little bit of growth in those two areas, but really the pie has stayed almost the same as far as the split. From a payer standpoint, we've had the biggest growth in Medicare and commercially insured patients. Our self-insured percentage has stayed pretty consistently. It dropped about 3%, which what that tells me to some extent is probably we had most of the self-pay already. We was taking care of at Paulding. And so we've added other people and they became less of a percentage. Medicaid dropped, probably for the same reason. One of the interesting things is that the commercially insured percentage stayed the same, but we grew in volume. So there was a growth in that sector. But the Medicare, where we had significant growth in percentages. And so I do think that was people that was probably leaving Paulding County for their health care that were going to other health systems. And we have seen them now come in, back into Wellstar because there's a facility here in the county. Because when they leave the county, a lot of them didn't go just to Cobb County, they went downtown. And we have a lot of those that we maybe haven't seen here. So we've seen a big growth in the Medicare percentages. And then from a media standpoint, most of you might have had a chance to see the TV stations coverage. We had great coverage, I think, from the TV stations. Tomorrow, I've already had an interview with U.S. News and World Report. Tomorrow, the photographer's coming out to take some pictures. The AJC did a great article in the business section. It's the front page of the business section on March the 31st, the day before we opened. And it was very good coverage. Atlanta Business Chronicle Becker report is a report that basically executives in healthcare look at on a regular basis. It's published by a group out of Chicago that they really focus on that piece that executives are going to look at. Health Design Magazine, Modern Healthcare Magazine, and then Health Facilities Magazine. That's the patient right there on the cover. That's the next one to come out. And so we've had a lot of media coverage. I appreciate all the coverage with Paulding.com. We had a lot of videos on Paulding.com and on YouTube that really, I think, helped people, inform people of what we were doing. I had a lot of people say, oh, I saw the video, and then you have to say which one, and and figure out, but we do appreciate all that. I think that was my last slide, because I think it's more important to find out what you might have questions about. I don't know how much time we still have. Yeah, so some questions. Yes.
You're talking about this building, the way it looked like you designed it, it is a green building. And you have LEED certification on that building yet, or you're applying for it?
Yeah, when we started talking about LEED certification. But there's two elements that I have to talk about. Now, if I have a real LEED supporter in here, I may ruffle some feathers. But when we looked at it critically, the administrative costs of keeping up with everything we were going to do for LEED was going to cost us over $500,000. And we, for one, just said we didn't want to see that kind of money go into paperwork. Secondly, LEED is a process of checking off, do I have solar? Do I have bicycle racks? Do I have this? It's not what percentage of the project is committed to that level. So we had engineers coming in saying, well, we could put a solar energy thing down on the pump for the irrigation system so that you can get some points. We didn't want to do that, but we are going to go for Energy Star. Most Wellstar hospitals and most hospitals that have been there for a while, their Energy Star rating is around 20 to 30. It's pretty poor. They weren't designed for energy. Most facilities today being built are going to aim to be about 60 to 70 Energy Star. We're hoping to get in that top quartile and as close to 90% as we can. And to me, that really goes hand in hand with healthcare, because really in healthcare, we measure outcomes. We don't measure necessarily how often do you do this before that. We don't measure the process, we measure the outcome. It's usually death rates, it's infection rates, it's rate of injury from a fall or something. It's looking at race, and to us, Energy Star matches what we're doing in healthcare as far as looking at the outcome of what you've done, not how you did it, but what is the outcome.
Have the ER wait times dropped at Kennesaw and Cobb when the Paulding opened? Did it help alleviate some stress on the rest of the system?
That's the reason why we think we've seen, that's part of the analysis that makes them feel that we got closer to 40%, is looking at the decline at the other hospitals. And they really haven't seen that much decline. Watching Douglas lately, they've actually increased in their ER visits. Kennesaw has seen very little change. Cobb gets the major brunt of what we're doing. Actually, the business plan that I'm doing for the next floor, they said just assume all the volume is going to come from Cobb. That all the Wellstar volume that you're going to take, which is they're saying 60% of it, is going to come from Cobb Hospital. And because we're looking at most of our growth is in that Powder Springs zip code when you look at Cobb County. And so they have seen decrease. Whether it's changed their waiting times or not, I don't know. I'll be honest with you, I'm rather impressed. Kennesaw's done a lot over the years, especially the last year, to change their waiting times. They've gotten rid of the hallway beds for the most part. There are some days when it just gets so crazy they have to bring hallway beds back. But there's been times I've gone up there and seen the waiting room almost empty. It surprises me because they are, for those that don't know, Kennesaw is actually the busiest ER in the state of Georgia. And they see 120,000 a year compared to what they say we're seeing 165 or 180 a day, they're seeing 350 to 400 a day. And it's a very busy ER, and yet we have 80 rooms. They have, they have 80 rooms. We have 40 rooms, and their rooms are all fairly small.
Mark, I was out of town for the open house. I'm really sorry I missed it, so this might be kind of a preliminary question. But you talk about building out the next floor. How many next floors are there? How many floors are built out? And what's your expansion capacity?
We shelled in 4 patient floors. Okay, the hospital's 8 stories tall. When you're looking at it from 278, you see 7 because one's below ground. There are 2 patient floors that are open today. There are 2 patient floors that are shelled in. And then we have a height variance to go 3 more floors, which would give us another 2 floors of patient care and 1 mechanical. So we can go basically from 56 today to 112 with the building you see today. And then actually add another 56 gets us up to about 165 or so for the future. And we built all the structure in to support that going up to 11 stories.
Are the floors replications of each other?
They are, although the next one we will probably make a few little changes, but it's like, okay, on the 4th floor today, every room has dialysis hookups. On the 5th floor, they don't have it because we felt like we could get all our dialysis patients on one floor. Well, it's caused some issues because we're so full that we may have the dialysis patient on the 5th floor and we can't get them down there, so we've had to create a temporary dialysis area, where on the next floor we would build in a permanent dialysis room for those patients. So.
Yes, the traditional Dallas hospital or traditional Paulding hospital also had a change in its mission, and I'm just curious where it stands.
It is, okay, it is still just as busy as it has been. They basically are 182 bed nursing center with running about 97% occupied all the time. Just to give you a piece of information, they actually get a 2% bonus from CMS, which is the group that manages Medicare and Medicaid. They get a 2% bonus in their payment because of high quality numbers. They have the highest rating, 5-star rating of all of nursing centers, and actually was listed in U.S. News and World Report as one of the best nursing centers in the country. And so where they are today is that we've had an architect go through looking at the rooms that we vacated, coming up with what would we have to do to meet the code that, or what would the state require us to do as far as being able to make them where we can provide nursing services in it. And not that you can't do it the way it is today, because today the second floor is exactly the same as the third floor. The third floor is what we vacated. But it's a whole grandfathering because building codes change. If we start renovating, we have to bring it up to a certain code. Well, it's sort of interesting that we would have to change that third floor when the second floor is exactly the same to do the same kind of care. So we're going to go to the state and try to get a waiver as much as possible, because so much of it's almost impractical that it can make it so expensive that you wouldn't want to do it. And so we've got to work with the state on that, and that's where we are on that.
Mark, I have a question. How long did it take to actually build the hospital, and how long would it take if you were to add those additional?
Okay, we started envisioning the new hospital in 2009. We started building the hospital April 2012. We opened the hospital April 2014. And by the way, that date was set in 2009. And we stuck to it. We stuck to the same budget we had in 2009. And to open the next floor, it will take 3 months of architectural work and then basically 8 months of construction. And so we could have it open within a year from the time that we say go.
That's great. Would that cause a lot of disruption to the rest of the operation?
No, because we planned on it. We actually, most of the pipes and everything that would have to go through are already through. We put in all the mechanical systems to support it. So all it is building out the rooms and putting the beds and furniture in it. Mayor?
You just made a statement that it would take 3 months' worth of architectural work. Well, if it's going to be identical to the floors below, don't you already have plans?
Well, it would probably have taken longer if they didn't know already what they were going to do. They're going to give themselves 3 months in their time frame. They probably can do it a little quicker, but they don't know how much we might change.
Oh, okay.
And but they've got to build it, to tell. They don't know necessarily who's the contractor might be at that point, because we will go out for pricing on contractors again to keep everybody honest. And that way, so they have to go through and build it. You connected this and that. I mean, it's got to all be drawn out again. And so architects and engineers are going to think they go get their money out of that too. Other questions? Yes.
But do we know what other types of buildings are going to surround the hospital? Are you all going to limit certain structures, so to speak, so that the hospital stays nice the way it is? Like, for example, the hospital room, you said that if you look out the window, there's trees now and it's beautiful. Do we anticipate things going up there? I don't know if you can answer that or not.
Well, no, it's actually very easy for me to answer it, because you cannot really control what's around you unless you own the land yourself. We don't own a lot of land around us. It's owned by other people. And the only thing that could control some of that would be an overlay district, where the county and cities, according to whichever land, if the land's in the city, it'd be a city overlay. If it's in the county, which a lot of land around us is in the county, it'd be a county overlay. That they can control some of the architectural features within that element, that area. But other than that, it's very difficult to really control what does happen around here. I do expect to see medical office buildings, but I do also expect to see retail come around us. Personally, I'd love to see a college campus. I think it's a great place for a college campus that has a focus on healthcare. I've talked to a few people about that already, but I do think that that's something. I think KSU, Georgia Highlands, needs that area place to grow. And I think Paulding County deserves, I think we've got a great technical college campus, but we need the campus that's going to support the university program, so that we can have people in our own community staying here, getting their bachelor's degrees and so forth, or masters. And so So I think there's a lot of avenues for that. And so I'm not advocating for that because that's actually one of my new little missions from a standpoint of, many of you may know, I'm involved with economic development too. And I do think that that is something that would be major for our economic development also. It was interesting to me, we met with an economic development company out of Chicago that was a site placement company. And we were talking about the new, I was sort of touting that healthcare is a major, you look at the education, healthcare, church community, other things. But I was talking about healthcare and the quality of healthcare. He said, well, what was more important to them was to see the local healthcare system investing at that level in Paulding County. That shows that the local healthcare system sees the value. And I never really thought about it that way, but that was to me an interesting comment. So, okay, thank you.
Thanks so much, Mark. I've got a couple of announcements. First of all, Georgia Classic Rides Block Party will be Saturday, June 28th in downtown Dallas. Visit the website for more details about Georgia Classic Rides at georgiaclassicrides.com.